Oh, it says live on Facebook. Meeting is now streaming live on Facebook. Okay.
So welcome to everybody who's joined this afternoon. My name is Carolyn Leary. I'm chair of the Sheffield ME Fibromyalgia Group. We are delighted today to be able to share with you an interview talk from Dr. David Tuller. Before we start, there's a few points I want to make before I invite Carol Binks to introduce David. A couple of technical things. This is live streaming to you on Facebook, on our Facebook events page. So whatever you can see, everybody will be seeing. We're going to continue at the end of the talk straight into a question and answer session after we've done the interview with David. If you are joining us through Zoom, which some of you are, I can see, there is a chat box on the right of the screen. You're welcome to ask questions as we go along, and I will pick them up as and when at various points. And we'll be monitoring the Facebook group for any live comments as well, which means you can feed back into the discussion. Once we get to the question and answer session, then people will be able to unmute themselves in order to ask questions live. We can explain how to do that at the end of the talk. And just to remind people, we have the power to mute people. So if you've suddenly got an incredible barking dog going on in the background, we might mute you out. So before we start, I just want to acknowledge we're in a pretty unprecedented time. The next month, I think, is going to be really, really challenging for the whole population, and especially for people who are living with conditions like ME, fibromyalgia, and other related conditions. We believe those people are probably at some greater risk, and the advice now would be that people are beginning to socially distance themselves. We are going to be constantly putting things on our Facebook groups and on our website, so please follow what we're saying and we're offering, and we'll be sharing information about ways in which people can access support and ways in which people can access the best possible information. We feel like holding this talk about medically unexplained symptoms, it sort of feels like coronavirus is the thing that's on everybody's minds at the moment. But actually, we think this has a kind of slightly uncanny relevance. We will be very surprised if at the end of this peak of the pandemic, there isn't an increased number of people who are suffering from post-viral symptoms and ultimately ME-type illnesses. So we feel that actually this talk is extremely relevant at this time, and sadly so. So without further ado, I would like to invite Carol to introduce David Tuller. And Carol, I'm very appreciative to you. You've put a lot of work into helping make this link happen and helping set up this opportunity for David to come and share with our group and the wider audience. So thank you very much, Carol.
Thanks, Carolyn. Thank you. So once again, we're delighted to welcome Dr. David Tuller to speak to Sheffield ME Fibromyalgia Group, albeit from the US this time rather than in person for obvious reasons. I'm sure that most of you will be aware of David and his work, but for those new to ME, David is a Senior Fellow of Public Health and Journalism at the University of California, Berkeley Center for Global Public Health. David writes prolifically on Professor Vincent Racaniello's virology blog, exposing poor science in the ME arena, and his investigative work has been so successful that since I think it's 2017, the ME community has, through crowdfunding, donated to Berkeley School of Health in Berkeley. This is a situation that we all hope will continue. David's work has included criticism of the PACE trial and the lightning process, amongst other things. And today he's speaking on the subject of medically unexplained symptoms, an issue which is highly relevant to sufferers of ME, fibromyalgia, and other chronic illnesses, as you will see. I'd like to thank David for agreeing to speak to us today in this modified format, due to the fact that he was unable to be with us in person as originally planned. And we hope it won't be too long before he's able to return to the UK. So before we welcome David, I think Carolyn just wants me to pass back to her to say a few words.
Thank you. Thanks,
Very
Carol.
much, Carol. Thanks for that. So we're going to run this as a sort of interview with some questions and some answers, by far the most interesting bit. So I'd like to start off really by asking David to just explain to us really what is MERS? What are medically unexplained symptoms?
Well, first I want to say thanks for, organizing this. As I explained when we set it up, I'm very technologically challenged, so I wasn't actually sure it would work, but it seems to be relatively easy. I'm hoping I don't have any glitches on my end, or my dog doesn't start barking too loudly. We are in a strange situation. And I also, I was supposed to come last week for the CMRC conference and then do this and some other things, but obviously it was not possible, or at least it was not feasible or not realistic to think about coming to the UK for a few weeks. So anyway, I'm glad to be able to do this now. I felt a little bit like I wasn't 100% sure that under the current circumstances it's completely the time to do it, but I think there is relevance, I think, to the issue that we've all been talking about, and it did seem there was still interest in going forward with this, so I'm happy to be here now. So, okay, so what is MUS? Well, MUS, as we know, stands for medically unexplained symptoms, and that's what it is. It's people who have symptoms that are not currently explainable by current tests or by current understanding, or is not explained by the particular physician or clinician that is seeing the patient. As on its own, it's a perfectly acceptable, okay concept, because obviously there are things that people present with to clinicians that are unexplained, and then you need to do investigations to figure out what they are. And if you can't figure out what they are, if the clinician can't, then they remain unexplained. Part of the issue with the term MUS, though, as it's been used more and more lately in the last 10 years or so, is that it's really come to mean, to the people who are promoting the concept, medically unexplainable symptoms, as opposed to medically unexplained currently. So instead of it being kind of a provisional category for all the things that we don't currently understand, which there are many of these things, it becomes kind of a static category in which it's determined that if we don't know what something is, then we can say that you have this thing called medically unexplained symptoms, which is defined solely by the fact that we don't know what it is. So it's sort of a non-thing that's been turned into a thing. It's sort of the absence of something that's been turned into like a positive thing, which we then sort of diagnose as MUS, and then do treatments based on the fact that you have MUS and not actually something. So that's the kind of standard concept. It has other names, bodily distress syndrome, functional somatic disorders. A lot of times these were called conversion disorders, by psychiatrists in the past, and still. So all these things that people tend not to understand get sort of lumped into this category as if they're all a thing called MUS, when the only thing that links all these things is that we don't actually understand what they are or what's causing them. And the presumption that they're unexplainable, then the default proposition, of course, has to be that they're explained not by physiological processes, but by mental ones or by psychological ones. So that becomes the default explanation when something is unexplained in this conceptualization or promotion of this as a concept or as a diagnosis. So my feeling is it's fine as a concept. It's a problematic thing as a diagnosis, where you're then doing treatment based on the idea that someone has a thing called MUS.
But it's interesting, isn't it? Because illnesses like ME itself tends to be diagnosed by the absence of anything else to be diagnosed. But you're saying that it's significantly different to an ME diagnosis.
In that sense, yeah, you broke up a little bit there, but yeah, so CFS, mainly the people who are talking about MUS would call the illness that we're talking about CFS or, you know, rather than ME. And they would, lump that into the category of medically unexplained symptoms because, it is essentially still unexplained. We know stuff about it, but it's not, explained in the way that other illnesses are. It's important to remember that everything that was once unexplained, that is explained, was once unexplained. So everything has been through, an unexplained phase, and then becomes explained. So the fact that something is unexplained now doesn't mean that it is forever unexplainable. And I think what's a fallacy of the concept as it's being used is that it sort of presumes that, it seems to presume, or the assumption must be, that we're sort of at the end of medical discovery if we sort of know for a fact that these phenomena that we're witnessing cannot be explained in any way ever by, pathophysiological processes. There's a lot of illnesses that we know have been in the past attributed to psychological factors or to non-pathophysiological factors, and now they're explained. And so, I think that it's quite arrogant to take an unexplained phenomenon and then just assume that it's forever unexplainable. And these people basically are suffering from some sort of psychological issue or need a psychological intervention to treat the illness, that they have. So it is in that sense, and chronic fatigue syndrome gets lumped into as an MUS, as does irritable bowel syndrome, and any other things that people that are not understandable. And in fact, in the UK, in the Improving Access to Psychological Therapies program, which is the NHS effort to sort of get everybody who might need it or who they think might need it into mostly cognitive behavior therapy. The MUS is defined as either chronic fatigue syndrome, irritable bowel syndrome, or MUS not otherwise defined. So that means any symptom, that's not irritable bowel syndrome or chronic fatigue syndrome, but just some random symptom that you keep having that they can't explain. That would be MUS, otherwise unspecified. So all those people, yeah.
We move on to the any of the kind of things that you want to share with us about possible treatments that are on offer. I just wondered whether you wanted to comment a little bit more on some of the history and some of the other terms, but also whether there's any kind of gender issues you would mention in that context as well.
You broke up a little bit there. I didn't quite get the question.
Okay. I'm just wondering whether you wanted to comment on history, some of the ways in which this has been described over time.
Okay, yeah.
The gender issues in relation to this.
Right. So there, yes, it is a very gendered issue. A lot of these unexplained symptoms would have been called hysteria, 100 years ago or 150 years ago, or neurasthenia, in the 19th century. Again, often conversion disorder. So the idea of that was that you have some psychological distress and you somatize it, or you sort of turn it into a physical symptom in a sort of conversion. You're converting your psychological distress into a physical symptom. Now, of course, there's not really any evidence for this. You can't prove anything like that. It's just an assumption or a hypothesis. But it has become completely accepted or it had been completely accepted, as the way things can happen. And so basically anything that people had that was unexplained, and again, hysteria, neurasthenia were predominantly, women who were diagnosed with these things. And a lot of these unexplained or, hard to understand illnesses or things that chronic complex conditions, autoimmune diseases, do have higher predominance of women identified as patients. And so there is, I think, a real gendered aspect to this. Other people might disagree. There are obviously men who have chronic fatigue syndrome also, who get badly treated. I tend to think it's because they're being treated like they have a women's disease. So they're being badly treated because they're not really treated as kind of, men, just like gay men have been treated in the past. But in any event, it's pretty clear that hysteria and neurasthenia and so on, which many things like MS, which used to be considered psychological, or people would have psychological things attributed to them. There was a new study recently of lupus, another autoimmune disease that just came out. And when they look at, it takes 6 or 7 years to get a diagnosis. So in all that time, those people have medically unexplained symptoms until they get a diagnosis. If you look at the way other people think about it, those people might be shunted off to cognitive behavior therapy because nobody could explain their symptoms for 6 or 7 years. And when you look at the misdiagnoses that people got, about half of the misdiagnoses that they got until then were psychological ones, that they had a psychological problem. So, the idea that we can sort of definitively say that someone has MUS and not some illness, to me, is a little bit of a, in many cases, or in most cases, perhaps, I don't know, but in many cases, certainly a delusion on the part of the clinician who is not capable or doesn't have these skills, or we don't have the test yet to fully diagnose things. So, I think there is a long history of, let's say, unwarranted certitude or unwarranted certainty on the part of the medical profession and on the part of the psychiatric profession about what things are. And they get the authority, for whatever reason, to sort of just declare these things are, MUS, and we don't have any other, they're not really anything. And so you need treatment, or, you have hysteria, as they used to tell people. And this is what you need to do, or you have neurasthenia. That's why you're tired all the time. So I think there's a long history of doctors, presuming that they know exactly what's going on and looking at the evidence in a way that really isn't warranted. And in this case, in the case of at least chronic fatigue syndrome and irritable bowel syndrome, doing studies that purport to prove that cognitive behavior therapy or other interventions are actually treating the illness when in fact they're not. The data don't show that. As we've
mentioned irritable bowel syndrome. Sorry, we're having difficulties with sound.
Oh, can you hear me? I'm not coming through?
I can hear you. I think it's me that's the problem.
Oh.
Could you say a little bit then about IBS and what you've found from the CBT studies?
Okay. Yes. So I recently have done some posts about irritable bowel syndrome. And again, as we are talking about the Improving Access to Psychological Therapies program that the National Health Service has, IBS, irritable bowel syndrome, and CFS/ME are the two named illnesses that fall under MUS. And so just to be clear, there are not, I hope maybe some viewers will not be from the UK, but the Improving Access to Psychological Therapies is a program designed to increase access to mainly cognitive behavior therapy interventions for people with anxiety and depression disorders. It was introduced about 10 years ago, I guess 11 or 12 years ago now. And then it was expanded to include not just people with depression and anxiety disorders, but people with long-term conditions. So someone with cancer or MS who also has other, depression or anxiety around that. And then people with MUS, medically unexplained symptoms. And the program specifically identifies chronic fatigue syndrome and irritable bowel syndrome as MUS. So we know from the PACE trial that this was the big effort, the quote definitive study to prove that CBT, cognitive behavior therapy, and graded exercise therapy are effective treatments for CFS or ME or whatever one is calling it at the moment. Again, I don't want to get into the name dispute about whether they're the same or different or whatever. Here it was being called CFS. That's what they were looking at. And we found, despite their claims, that they basically had findings that did not support their claim that these treatments worked to improve anything. However, that's what's recommended through the IAPT program because of PACE and other studies like it. And it's worth pointing out that the same researchers who are doing PACE, the irritable bowel study syndrome, and so on are also some of them consultants to the IAPT program and so on. So they're sort of doing double duty in both doing the research and then promoting the research to the program and sort of suggesting that these strategies are warranted. So what's happened with irritable bowel syndrome? So they did a big study of 558 people based on smaller studies, and they compared telephone delivered cognitive behavior therapy, web delivered cognitive behavior therapy, and treatment as usual. So basically, these are patients who have had IBS for at least 12 months, so they still have it. So treatment as usual is not doing anything for them because they still have it. And so this study, like PACE, was an open label study. So everybody knew what treatment they were getting. So that's understandable because it's hard to blind, web-based cognitive behavior therapy. At the same time, all the findings were based on, were self-reported. So basically at the end, they just said, do you feel better, essentially, in different ways. And so we, and they also told people in the cognitive behavior therapy manuals that this has been shown, cognitive behavior therapy can make you better, or research suggests that this will make you better, or they were getting positive messages about the benefits of cognitive behavior therapy as they were in PACE, while people in the other arm were not getting anything. Any of these messages in the treatment as usual. Anyway, at the end of the study, last year they published 12-month results and then 24-month results. In the 12-month results, those who got so the main one of they had 3 questionnaires or 3 measures that they used. Only one of them was specifically about how bad the symptoms were. Symptoms, it's called the symptom severity, IBS symptom severity score or symptom severity scale. So that one is a 500-point scale, and it's understood that you need 50-point change. If I took it and then I took it again, I would need to get a lower by 50 points or more for it to be considered a clinically significant improvement. If I improve by 35 points, say, in that 500-point scale, it's not considered clinically significant. So it's still an improvement, but I might not experience it clinically because it's not really very much. So in the study, when they looked at the averages after 12 months of the people who reported, and then also about 30% dropped out, they didn't report at 12 months, so they then do an analysis trying to figure out what those data might have been. Anyway, their conclusion was that those in the telephone therapy arm had 61-point lower more of a reduction in their score than those who got treatment as usual. So those people got what would be considered clinically significant reduction at 12 months, but that's the telephone CBT. The web-based CBT, where people were doing it just on an online program with a little bit of telephone support, they only had a 35% less better score. 35-point better score than the treatment as usual arm. Now, 35 points, I think we can all agree, is fairly significantly less than 50 points. And therefore, this 34% average, this 35-point average drop or average difference between the two groups is not really clinically significant. That's at 12 months. At 24 months, the web-based group only had a difference of 12 points, and that wasn't even statistically significant. And in the telephone group, that had fallen to 40 points difference. And so that was still statistically significant, but it was no longer clinically significant. Okay, so what does that mean? They did have improvements in the other 2 questionnaires that they got. One of these was a depression and anxiety scale. So that had some modest improvements as well. A modest benefits for the CBT over the treatment as usual. And the other scale was what they call a work and social adjustment scale, which is, does your illness interfere with your, work, or does your illness interfere with socializing and so on? So that is related to IBS in a sort of way, but it's a kind of generic domain. It's not about the symptoms specifically, it's about your adjustment to your symptoms or your adjustment to your illness. Now, it's pretty clear that a round of CBT could be expected to improve both of those measures. You might be able to adjust better, but they clearly did not get much improvement in symptoms. However, in their great wisdom, King's College London, which apparently has the license for this study, has licensed the web-based program that did not produce clinically significant findings according to their own study, and has licensed that to a US company in San Francisco to produce, to license this, to disseminate it. And so it's being promoted by this company. So it's being reviewed by the NHS for the IAPT program. And it's going to be, I presume, or has been maybe, or will be submitted to the FDA, Food and Drug Administration here. And basically, they're claiming on the website that they have, the findings are groundbreaking, what did they say? Dramatic and potentially game-changing and so on, when, they're nothing. The findings are for the specifics of symptom severity, which they're claiming are dramatic changes, they're not clinically significant. So it's all nonsense. And one of the co-lead investigator, one of them is Trudy Chalder, who is a lead investigator of the PACE trial. And the other one is Professor Rona Moss-Morris, also from King's College London. And she is a consultant to Mahana, the company licensing it. And she also has stock options in Mahana, which is the company. So she has a serious vested interest in this. Now, these interests are disclosed in her disclosures, but when King's College London put out their press release about the study and claimed how great it was, they didn't mention anything about her conflicts of interest or her interest in this company. The claim in the the claim is that the payments, the financial involvement occurred after the study was submitted for publication. That may be so. I have no reason to doubt that. But whether or not it's so, she has a clear interest in the company's success. And she's quoted as saying that this is an effective treatment for IBS. The study clearly shows it's not an effective treatment for IBS. It's an effective maybe treatment for your feelings about your IBS and maybe for any depression you might have. But again, that's to be expected. If you have a round of CBT, you might feel a little less depressed. That's not surprising. That's very different from claiming this is a treatment for your IBS symptoms, which is what it is saying to say this is a treatment for IBS. So what's going to happen? This will likely be approved as a treatment for IBS through, say, IAPT program, and people will be sent to this if they're not helped by other things and told that this is an evidence-based treatment for IBS when it is simply not. That is not true. And, again, this seems to have been set up as the definitive study specifically so that it could be, used for IAPT program. And it doesn't work for what it says it's supposed to do, and they're still promoting it as if it does. It's very Trumpian from my perspective. It's a very Trumpian kind of logic that these people seem to use, and that the universities seem to use, and that the companies seem to use. So about this issue, I've written a couple of times to the co-lead investigator. I've written to the CEO of the company. I've written to, the company has multiple prominent gastroenterology advisors, psychology advisors. I've written to some of them. Nobody has responded to any of my questions. Nobody's explained to me why they're promoting these non-results as dramatic and game-changing. And, that's where that is. So basically, the two illnesses that sort of fall under the MUS umbrella, in anyway, at least in the Improving Access to Psychological Therapies program, it turns out that the studies designed to prove that the treatments being offered work show that they don't. So that's, basically the situation. Now, it turns out that they're also looking at, Trudy Chalder just published a study about fatigue in HIV. So, that's another illness. And I can imagine they will try to be promoting cognitive behavior therapy for fatigue for HIV. And the study has some of the same problems that all their studies have, which is that, well, they're just doing bad science. They're making assumptions about causes based on associations. And it's really a fallacious kind of reasoning that they constantly use to claim their hypothesis is true when in fact it's just a hypothesis.
Goodness.
Sorry, I went on for a long time there. I hope that was understandable. I was going to do it when I came with slides and everything, but you know, next time when I come, I can do it with slides.
Yeah, no, absolutely understandable. Do you have some comments as well about lupus?
About
lupus?
Oh, about lupus. You know, I don't. You know, again, I don't know much about lupus, except as I said, I read the article recently that was published just recently. About the misdiagnoses and how long it takes to get a diagnosis, again, 6 or 7 years, and that half the people who had been given misdiagnoses in that time, almost half were given psychologically oriented misdiagnoses. So in studies about MUS, those people, you know, they don't usually look 6 years out to see if someone still has something unexplained. So those people would have fallen into the category of MUS and might have been sent off for cognitive behavior therapy because they had been given a presumptive diagnosis that they were just having, you know, symptoms related to some psychological issues, as opposed to the fact that they were having an autoimmune disease that took 7 years to get diagnosed. So again, I think that study documents that MUS is not a problem concept. It's just if you apply the term as if it's a rigid category, and that people, you know, definitively have, you know, you decide that they definitively have psychological problems based on, you know, an inadequate examination or an inadequate examination that's the best you can do at the moment. It's really a problem, because then you're sending them off for treatment that isn't related to what they have. And then if they don't get better, they're blamed for not getting better. So it's a little bit insane making for patients.
I was just wondering whether I could mention to all the people who are participating, if you'd like to send any questions in through the Zoom chat group or on the Facebook events page, please do. We did have an earlier question, which is about asking whether you have any further comments about EDS. Us down, Ross.
You know, I don't, nothing specific. Was there anything, was the question specific at all, or just do I know anything about EDS?
It was, I think it's probably the similar set of questions really about treatment regimes.
You know, I'm very reluctant to sort of talk about treatments because I'm not a clinician and nobody should be listening to me about what treatments are recommended, or, you know, I mean, I can just say what I read, but I'm certainly not somebody who should be giving advice about treatments. You know, with EDS, it seems obvious that there's, you know, overlap, a lot of overlap, and it's not really clear, as far as I understand it, what exactly the overlap means. There's multiple kinds of EDS and so on. So, you know, I think there's obviously a lot of categories of, you know, mast cell activation, all these sort of things that are, you know, not new, but sort of some of them emerging, and how they all relate and what they all are is very complicated and not something that I'm sort of prepared to really discuss.
Okay. I mean, we're particularly interested in the, you know, apparent growth of talking locally about how much IAPT services are offered to people, both in general terms. So they might be programs around dealing with stress, there might be programs around dealing fatigue generally. So the IAPT programs that we're aware of in Sheffield are not specifically set up for people with chronic fatigue syndrome or ME or fibromyalgia, or those sort of more specific diagnoses. These are very, very broad brush programs. So, and it certainly would appear to be the case that staff and patients alike feel that there is a kind of expectation of improvement that influences somehow how they give their feedback at the end.
Well, I think that is likely. I've heard that too, and that's likely true. And, you know, I think they're obviously giving themselves marks that are better than probably warranted, according to some of the analyses. I mean, the IAPT program, are people saying IAPT? How are they calling it?
Yes, IAPT.
IAPT, okay, IAPT, okay, IAPT. And I'm sure it's being, rolled out differently in different areas. And I'm sure in some areas, and I mean, basically, I don't have a problem. Psychotherapy is, I've had a lot of psychotherapy in my life. It's not like I'm against psychotherapy for people who, when people have issues they want to work out. And so if people are coming to primary care and they have the primary, the GP just thinks they have, depression, anxiety, great that they can be easily referred for therapy, I guess, and I have, but, if it's treated as kind of a cure-all for my impression being in the UK is that we don't talk as much about CBT in the US as in the UK. I get the impression in the UK that if people go for psychotherapy, they're going for CBT, or if people go for, anything, it's CBT. And there's this idea that CBT is some magic bullet that can cure anything. People don't seem to talk about it, or maybe it's just that I'm more immersed in this topic now, but certainly I never really heard about it as kind of the general, template of psychotherapy that people go to if they go to in the US. But so it's not a negative. It's just that the way it's applied, it seems like any bureaucratic system, once it gets going, it sort of has a self-replicating tendency. And I think there's been a real certainly, as this has been rolled out, as I pointed out in my reporting, that they really exaggerated the cost of, quote, MUS to the country. Basically, there was a study about in 2010 that tried to estimate the cost of I say so-called MUS because the category seems to be squishy, but of so-called MUS to the National Health Service in England. And it found that according to their statistics, which were problematic to begin with. Well, not problematic, but the way they did, I don't necessarily agree with the way they did the estimation. But anyway, their estimate was that 10% of the NHS budget spent on working age people was spent treating people who presented with MUS. So that's a fairly high number. But in many of the studies then promoting the need for IAPT and how much MUS costs the economy, that got translated into 10% of the entire NHS budget. And so basically all these top leaders of this movement showed that they were incapable of reading a seminal study in the field of research that they claimed to be an expert in. So a couple of high-profile studies, including one which was co-authored, the co-lead investigators are Trudy Chalder and Professor Rona Moss-Morris, they had to correct the opening paragraph of their protocol for another study of MUS because they misquoted this seminal study. And and so this has been misquoted all over the place in these studies by these people and in presentations, and they don't seem to care. And it's taken a while. It took a while to get, one correction. I argued with the editor about whether they should correct it or not. And he was like, well, it's 10 years, the data's 10 years old. And I'm like, yeah, but you published it 2 years ago. So what does it matter? Is there a statute of limitations on incorrect data if you have a publication? So, and then he said, well, why don't you send me a sentence or two, a short sentence or two about it? And I said, no, I'm not going to do that. It's your job to correct bad information in your publication. So finally, they corrected it. That was in the British Journal of General Practice. And, it's astonishing to me as a reporter who, really goes out of his way to correct anything that I notice is a mistake as soon as I notice it, or when I notice it, or when someone points it out. I don't necessarily wait till someone points out a mistake to correct it. These people are just like incorrigible. They just don't care if they have a mistake. Or they care, but they don't really think it's important to correct them, apparently, until they're forced to.
I think we've all been incredibly impressed by your attention to detail and your persistence in terms of absolutely pursuing some of these inaccuracies and on behalf of our community. So we're extremely grateful for that. We've got quite a number of comments coming through, which are people talking about having been, many people get offered CBT. I think psychotherapy in the UK does exist as a separate thing in its own right. And I think psychotherapists have a huge range of other tools that they use and access in relation to all sorts of different issues. So I can imagine any psychotherapist watching would feel they wouldn't want their whole art and craft and science to be sort of encapsulated in the CBT model. But nevertheless, I think many people who we're in touch with are offered CBT in various ways and various forms, not particularly specific for ME, but in general terms. And you know, lots of people say, you know, some helpful management strategies, some helpful things about meeting other people and sharing some of that. You know, we're grateful for something rather than nothing. But you know, but all these comments that are coming through are all saying, you know, it's not cured me, it's not changed my symptoms, it's not made me any better, but it does seem to be all that we seem to get offered. But also that people have to play this kind of thing with their GPs, where their GPs refer them, and so they have to take seriously what the GPs recommended in order to come back to the GP for further support. So there's a very, as well as the actual evidence of CBT and whether it makes a difference, which generally most people appear to say it doesn't, although it does provide some level of support, it just feels that people are in an impossible position where they have to accept some of these offers, whether they want them or not.
You know, it's a terrible situation when you have to accept treatment that you don't think is really good treatment just to keep on the good side of your doctors, and you have to go through the motions of doing stuff that you don't think is useful. It's just silly, and it's a waste of resources. And it just is, you know, I mean, you know, everybody, we don't have a healthcare system in the US, essentially. We have, you know, 500 million different systems, and they don't, you know, function well together. On the other hand, because we have so many independent sort of structures, there's a lot more freedom if you have good health insurance in our country. If you have a good job that provides you with good health insurance, you have more options to, you know, not to refuse treatments, or, you know, I'm in San Francisco. If I want my primary care doctor to be in LA, that's my business. It's not my insurance company's business, you know. So I think, you know, there are benefits to having a national health system, but there are also, I wouldn't say there's benefits to not having one, but there is some flexibility in the system that we have. Again, only if you have health insurance, that seemed to be lacking in the British one. And I find it very distressing when I hear people have to go to a GP that they don't like, or that they can't go to another one, or that they have to do things that they're not, you know, really happy about.
I mean, there are options in moving your GP, but it's certainly not easy or straightforward. I think there is also, you know, again, various comments coming through. There is a certain amount of confusion from GPs about what the specialist services, chronic fatigue services, offer. Certainly one comment here suggested that their chronic fatigue service said that ME was a mental health issue. There is an expectation that chronic fatigue services, specialist services, are delivered by clinicians, and on the whole they're delivered by, you know, occupational health people in Sheffield, for example, or psychologists, or, you know, it's got a very sort of non-clinical slant to it, which I think is difficult. So one of the questions that's come up is do you know much about how general practitioners are trained about MUS, either in this country or in the States?
So how much general practitioners know?
Yes, or are trained in medically unexplained symptoms.
Well, I think, you know, I don't know how they're trained very, very little, as we know, about chronic fatigue syndrome. And I would guess, I don't know how much about medically unexplained symptoms are trained in, you know, in schools. I will say that there do seem to be a lot more, you know, Mayo Clinic, you know, I had a seminar last year about medically unexplained symptoms, and there do seem to be a lot more of a kind of educational programs that are sort of structured around that kind of concept. You know, and I assume it's easier, you know, it's easier for GPs if they don't understand something to just say medically unexplained symptoms. You know, the idea that, you know, some of these rates of, you know, what percentage of people come with medically unexplained symptoms to the GP? Well, of course you go to the GP with symptoms that are, you know, there's nothing, that's the job to figure out what things are. So it's not unusual to present to the GP with medically unexplained symptoms. You know, every symptom is unexplained until it's explained. So but I think GPs, when they don't understand something, you know, if you say it's medically unexplained symptoms, then you've explained it. So you don't have to then explain it anymore. I think hopefully GPs, can have enough humility to say, we don't know what something is. I think that there needs to be a lot of more ability maybe of clinicians to say, we don't know. We just don't have the answer for this at the moment. And that, it maybe it's psychological, but it very likely could be some other, some physiological problem. This isn't related to ME specifically, but just MUS in general. I hadn't heard until I got into, this project about MUS as a general thing. And so I haven't yet figured out how much it's in the discussion. It seems to be pretty rapidly disseminating kind of concept that you see a lot more and more. So I for better or worse.
Lead to a talk done by the, sorry? Okay, am I unmuted? Yeah. I very recently attended a talk delivered by somebody who works in our local chronic fatigue service, and it was a talk to the Student Psychiatric Society in Sheffield. The information they were given was that 50% of patients go to their GPs and have no structural pathology that explains their symptoms. So the
okay.
Yeah, so what was being implied through the whole of that presentation is that MUS is a kind of epidemic or pandemic, that many patients are going with psychological symptoms, and that actually that's the norm. So it was, I found, an incredibly disturbing talk, but that is the pervasive view, and it's pervasive view locally.
Well, I think, it's very easy for a science or for a discipline that doesn't actually have to prove what it's saying, which is where psychiatry is, because they can just make up theories about things and there's actually no evidence for it. I mean, they can't, again, the only evidence that someone might have a psychological problem is that the absence of the evidence that they have of the current evidence they have a physiological problem. Now, look, maybe somebody is twitching their hand, or maybe somebody has a tic, or maybe somebody has, I don't know, psychogenic seizures, as they call them, and so on. Whatever, I don't know. But when the evidence that it's produced by mental, processes or psychologically driven, is just that they haven't yet identified a pathophysiological cause, then I'm skeptical. And when I see, basically I've based my interpretations of things on the science. And so I'm not the one who's claiming that CBT can cure chronic fatigue syndrome. All I'm doing is looking at their study and saying, well, you claim this based on your study, but you're actually not proving it. I'm not the one claiming to know how to cure irritable bowel syndrome or claiming that anything. I'm just saying, making claims on studies that you can't make. So, I don't know what these things are. I don't know why people have them. Maybe some people can benefit by CBT for them. All I'm saying is that the evidence that's being presented for that doesn't make that case. So, I'm really basing my arguments not on the ins and outs of someone's pathophysiology, but just on the study design and on what they're claiming about the study. And so I've always been hesitant to sort of try to make claims about, what I think MUS is or what I think CFS is. I don't know. All I know is what the scientists say. And I'm looking at, this body of research, which is making claims that they really have no business making.
Okay, thank you. I'm going to ask just a couple more questions, which are from people who've joined the chat. And then we're going to open it up for people to ask you direct questions. Just to kind of emphasize David's last point, which is obviously not in a position to answer questions about treatment regimes or some of the kind of detailed clinical issues, but much more about quality of research and how that informs policy and design of services. Do there's an interest in what you're planning on doing next. Might you write a book? Is there going to be more crowdfunding? So thanks to Tricia and to Polly for those questions.
Well, so yeah, I've been crowdfunding in April. So Berkeley has its crowdfunding platform, which it opens up 3 or 4 times a year for a month. So I've done it once a year in April the last couple of years. And so it's still going on in April. So I'm going to crowdfund again, but, I don't know, it's a weird time. And so I likely will crowdfund twice this year because I don't know how this is going to go in this time, just because of the timing of everything. So basically I thought about doing a book. I did one book many years ago, and I haven't really had that many urges to do another book. I kind of like writing things and then they're out and then you write something else in a book, but we'll see, maybe next year. I'm 63. I can, I have more time to work, but I'm not going to do this indefinitely, but definitely I'll do it for another year or so. And I will continue. I feel like PACE is kind of, I think done as a piece of legitimate research. It's still influential, obviously, and so on, but I feel like I've done what I can with it for the most part. If the establishment refuses to accept that it's a piece of crap, there's not much more I can do, except that's all out there. I do want to keep looking at sort of these other sort of tributaries, more about MUS and some of the other, research coming out about chronic fatigue syndrome, or ME, I should say. And, I'm trying to keep up with what's going on in developments in other countries. I haven't done as much travel this year for various reasons. And now, I was supposed to come to England for a month and do stuff. And obviously that I can't do that at the moment. So I do want to keep looking also at more at what's going on in the US with the NIH and the CDC. I think it's very difficult because I'm one person and this has been, supposed to be a, 50 half-time job. And, there's so many countries and so many issues and, it's very fascinating, but it can be very frustrating. And, then there's a lot of issues about case definition, there's a lot of, concerns about, which case definition is being used for research. And then there's a lot of issues around, what even is triggering it, is it just an infectious agent? Is it mold? So people talk about mold. Is it, other environmental triggers? There's all the stuff about, with some high-profile people getting neck and so on surgeries. What's that about? I haven't looked at that. So there's a lot of stuff to write about. It's just a question of having the time. And I wish other people were interested in reporting on it. I think, I'm trying to get more out in, I think it was good to get the piece in Stat this year about the lightning process study. So I'm going to try to do more of that this year in terms of getting issues out in other, outside the virology blog bubble.
An awful lot to do. So
so it's a lot to do. I can go on. There's all sorts of things to do. Whether what I'll get to exactly is another question. I'd like to have more time to be able to work on it. So, I kind of muddle through. I think this was a pretty. I had a lot of corrections this year. So they were like, the lightning process study correction. It should have been retracted, but still, I think the study is tainted. And hard to use as a authoritative citation to support the lightning process. I think it's really been tainted. And, I think, we'll see. I'll just keep plugging away. And, basically, it's very easy for the writing letters to interested people and sort of trying to embarrass them publicly is something that I think, it takes time to work, but I think over time starts to have an effect. And so I'm going to keep doing that with some of this stuff also.
I'm very grateful to you for doing that. There's a question from Laura, which is, do you think the science will ever win over the psychological argument?
Do I think the
science will ever win over the psychological argument? That's got a bit of relevance to.
Yes, I think it's very well.
The virus.
I hope so. It's dismaying that the UK, when it comes to at least the PACE study, has had an emperor has no clothes perspective, where really it is obvious to any reasonable researcher that a study in which people could meet outcome measures at baseline is a non-starter and, will not fly.
I think we're all kind of hoping that maybe the consultation on the NICE guidelines may move us on a little bit.
So basically,
we'll move on. Yeah.
I think that that's supposed to come out at the end of this year. We'll see. I mean, look, the coronavirus situation may delay everything and may put other research on hold for a while. Who knows? We don't really know. So I think. I think in the U.S., not that people can get good treatment now, but and still clinicians will tell people they don't understand, but sort of at least on an official level, people might differ on this, but on a gross level and a crude level, there's still a lot of problems, but we don't have official pronouncements about, psychological stuff going on. And the CDC, as bad as they've been on many levels, the Centers for Disease Control, has removed a couple of years ago the recommendations for CBT and GET, although they're still bad in many ways because they still have squishy language and so on. So there's been more change in the US on that front than it seems in the UK in terms of debunking or dethroning the PACE paradigm. When that will happen here, I don't know. I think it will, likely, take, certainly when there is evidence of biomarkers or, verified or, accepted biomarkers and accepted medical treatments, that will certainly, I think, make a difference as it has with other illnesses. I think until then, it's still going to probably be a struggle given the apparent power of people who will make arguments based on bad evidence to influence the healthcare system and so on. I think a lot of it seems to be about the NHS saving money, as far as I can tell. But it's hard to predict that. I was very naive when I started this, and I thought if you point out all the flaws in the study, that it wouldn't survive. Certainly, if that was about another illness, the PACE study would not have survived.
We have an interesting point here from Rebecca, who is wondering whether the emphasis on MERS is partly because as she describes it, the psychological tribe in the UK feel threatened by some of the new studies and better science around ME. So I think she's wondering whether MERS is almost on the increase a bit as a concept.
I mean, it could be, it could be. It's certainly a way of expanding one's, domain. I think, there seems to be a movement to offer CBT to everybody. And so I was interested when I saw and just recently wrote about the HIV fatigue study, which is also, again, they weren't recommending CBT because it wasn't a treatment study. It was just looking at correlates of fatigue related to HIV. So again, they're making, they're expanding they have the same hypothesis for everything. Boom and bust, cycle, people afraid of activity, people need to then have cognitive restructuring so that they can get back to activity. And, they look at this study was like, okay, people who have greater HIV, who report more fatigue, let me see if I can remember, who reported more severe fatigue were more likely to also be so-called catastrophizing their fatigue or symptom focusing, and were more likely a year later to still be having severe fatigue. They feel this confirms their hypothesis that focusing on fatigue when you have HIV exacerbates the fatigue and makes it worse. This is totally ridiculous because it's just totally misinterpreting the data. It's very likely that people who have more fatigue are going to be more focused on their fatigue and are going to more likely to have fatigue a year later. So they sort of interpret their data backwards. They look at an association between thinking about your fatigue a lot and having fatigue, and decide that thinking about the fatigue causes the fatigue or exacerbates the fatigue, instead of the other way around, which is more logical, that you have a lot of fatigue and therefore you're thinking about it a lot. And so there's the same logic they did with PACE. If you think your fatigue's not going to get better, it won't get better. And they use that to prove that the ideation about your fatigue in ME or chronic fatigue syndrome is what's causing your continued fatigue. It's just interpreting data backwards for no reason other than that it fits their hypothesis.
It's yeah, there's some
I don't know if that answers the question actually, but I think yes, I think that they're probably feeling that the ME window may be shutting, and that's moving in a different direction, and so now they've expanded it to all these, everything. Through the IAPT program, everybody can get cognitive behavior therapy for whatever illness they have.
And obviously, any treatments offered are certainly informed by the amount of money available. There's a question here from Moira about whether you've got any plans to look at how the insurance companies ignore evidence, so that to the detriment of people with ME who are wanting things like salary protection. Have you ever done any work around insurance companies?
I've done a little bit about insurance companies and the conflicts of interest of the PACE investigators. It's a little complicated because it's so different in every country. And so, it's one system in the US. So basically some things you can write about that apply to everybody if you're looking at a study and it's bad or something. And other things are very specific to the country, so yes, I would like to look at that stuff. I would like to look at it more. I'd like to look at more about disability insurance and the issues people have. So yes, but will I get to it, or, with everything else, it's very frustrating. Everything seems critical to do. There's so many things to write about, and one person.
Indeed. Can I open this up then to anybody who wants to call in with a question?
Sure.
You can now unmute yourselves.
So anybody calling in has the power now to unmute themselves so that we can hear their question. We might get several at once and we'll have to handle it. Is there anybody there? Okay. What I will as well is there was another question which appeared on the chat room, which is around the accountability for the quality of this science, which I know has been something that's worried you for all the way through.
The accountability for the quality of the baseball?
Yeah.
What accountability?
Mm.
There is none. As far as I can tell. I mean, the Lancet, basically when journals ignore their own guidelines and cover up and refuse to acknowledge serious flaws in their work, then there's not really a lot of accountability. I think, yeah, I mean, I've been shocked. The level of accountability is such that when I point out problems, I get complaints to Berkeley, to the chancellor at Berkeley, about my work or about my behavior, which was what University of Bristol complained about. They complained about my behavior. My behavior consisted of writing about bad research and probably doing it somewhat obnoxiously, but certainly That's my right. I can be obnoxious if I want, as long as I'm accurate. And I was. And so, you know, when a university, instead of investigating its own researcher who's committed, arguably committed serious violations of basic scientific guidelines, and instead, instead files complaints with someone else's university, you know, I would say there's very little accountability in the system.
There's a question from Annette, which is, what is the best way to fight them? How do we, as a community, demand an adherence to science? That's a comment from Eric.
Well, I mean, I think countering the science is important. You know, I think I got into this because I read the patients', you know, accounts of the study, and so I thought, well, I found them convincing. So I think that's important, even if it looks like, you know, no one's going to pay attention ever. I think it's important that, you know, debate be, you know, within bounds. Now, within bounds is considered different in the US, of course, than in the UK. I consider it within bounds. So I consider it in bounds to critique these studies, but when you critique the studies, you get accused of harassment. So it's really a challenge, because if every critique, you know, it's really very, again, I come back to President Trump. He just indicated that a woman who asked him at a press conference the other day, who asked him why the White House had disbanded its pandemic team, he called it a nasty question. That's the same logic that people use, that the PACE authors use. If they don't like a question, it's harassment. So I think patients, especially in the UK, are in a really difficult position, because everything you challenge, you get accused of harassment. And I think I've come to the conclusion that the culture of deference, I mean, we have issues of research misconduct here, it's not like that, but I think that there is something about the culture of deference that's very much a problem for scientific inquiry and for robust scientific debate. At least in this domain, it's appeared to me that there's a much greater sensitivity to robust criticism in the UK, and that it's much easier to convert that into claims of harassment than would be, you know, kind of typical in the US. I think some of the criticisms I've gotten are so ridiculous, and some of the claims by people like Professor Sharp are so absurd and out of bounds that at the US, it wouldn't really, it would seem odd to me to be getting that kind of, you know, kind of reaction. You know, all I've done is point out bad research in you know, and I think patients are, you know, and patients have been gaslighted. And I think it's important for patients on, you know, mental health to be able to recognize that and to keep speaking up. You know, I think it has had an impact in the UK. I think it looks very, very slow from the perspective of a sick patient. I can see that, but I do think there has been some change. It's not like completely, you know, like it was 5 years ago. I don't think.
Taking the science down to an individual level, there's a comment from Richard here, which is about, you know, the fight itself is exhausting, and what techniques to use to get your GP on side. Have you got any experience or examples where patients have used some kind of more scientific presentation of their own symptoms or their own conditions?
I've heard cases where patients take one of the letters to the Lancet to their clinician, you know, and say, look, this is other people object to this, or, you know, the reanalysis paper for the PACE study. So, I mean, I've tried to, so I'm aware that I've tried to sort of write those as things that people could use in that way, if that is helpful to them. So, and some people have told me that those things have been helpful. And, you know, I mean, I think, you know, bring them in, you know, so there've been some decent newspaper articles. The Times of London had an article last, you know, was it last? I can't even remember now. Last year, I guess, about the letter to the Lancet with 100+ signatures. So, you know, that you can show that to your GP. you know, they may not even be aware that there's objections to PACE is part of the issue, I think, or that there are objections to PACE from beyond outside the patient group. You know, that they're actual, you know, respectable and high profile and prominent clinicians and scientists who think that the PACE study is a piece of crap. And in fact, there are quite a lot who would tell you that it's research misconduct, you know, who would say that they think it is. And so I think, you know, I think GPs, I have every sympathy for GPs. They're so stressed, you know, they see so many people. In the US, they have like 12-minute appointments to cover everything. It's really, really, really difficult. And so I don't blame GPs for, you know, not reading all the papers and for not knowing everything and for taking the advice that they're given, which is that exercise and psychotherapy are the best treatments for this. So I don't, you know, it's hard to blame clinicians for not knowing everything. They can't about everything. So I think it is to a certain degree up to patients to educate their clinicians, unfortunately, in cases where that's warranted, or in cases where patients know more about their illness than the GP does.
Well, maybe that helpfully leads us to a kind of final comment then, which is maybe that gives a task for the Sheffield group to actually prepare and put together a pack of some of that core information so that it's more accessible for people to take with and present to their GPs.
I think that's a great idea.
A little bit more persuasive, and I'm sure we can certainly get that together and make that available on our website. So I think I'm going to throw it. If there's any other last questions coming from the audience.
I just think that one thing about, when I started this, I assumed the PACE trial would be retracted. I just didn't think it could survive. And so I had to really adjust my thinking about what my goals were. And I realized I just couldn't sort of get things retracted. You know, that my goal had to be, you know, discrediting work as opposed to, because I didn't have any control over retraction. And so, but and part of the reason I want retraction is so it can't get cited, so it can't get used, you know, to harm people. Now, hopefully, with the NICE guidance coming out later this year, that will be a decent guidance and sort of, you know, will not necessarily recommend the things that have been recommended in the past. But I have been conscious of trying to do things so that there are documents that people can take to their clinician to say, you know, like the letters, like other people disagree with this, even though this study is still in literature. Here's all these people who say it doesn't prove what it says. So I hope that people can use things in that way. And I think it would be good if there were like a, you know, a fact sheet or something referencing some of this material.
There's a lot of material to reference, isn't there? So
at this
that's
point,
a challenge for us, yes.
At this point, there's quite a lot.
Sorry, say that again.
At this point, there's more than there was, at least. So I think, yeah.
Good, isn't it? That's a good sign. So if there aren't any further questions coming through live, I would like to echo Annette's comment, which is a thank you to Dr. Tuller for everything that you have done and everything that you are doing. We're very, very grateful that you've made today's talk possible. I'm hoping that next time you come back into the UK that you'll be able to come visit us again, and maybe things, well, who knows, the world will be a very different place next time you come.
Yeah, let's hope this doesn't last too long.
And I have no idea what that's going to look like. So can I say a huge thank you then, and thank you to everybody who's helped me set this up. Thank you to Carol. Thank you to Sean, who's been here doing a lot of the technical backup. I hope the quality of the live stream has been okay. I know there's a couple of little bits of glitches in the middle, but nothing major. We've got a feedback form which we'd love you to fill in. Not you, David, but everybody who's listening. So we've put that on the chat, and the link is bit.ly, which is bit.ly /feedback SMEFG. That's Sheffield ME Fibromyalgia Group. And we welcome that feedback.
When will the link get posted to the whole thing so people can listen to it if they didn't hear it?
So from here, this live stream will now be downloaded and then uploaded onto YouTube, and we will make that link available to to our 2 Facebook groups, to our website, and any other places we can find to put the link. So things like Science for ME, and we'll put the link out as widely as we possibly can.
Okay.
So a huge final thank you to you, and enjoy the rest of your day, because it's early morning for you, very early morning.
I plan to self-isolate for the rest of the day. I have to go to the bank, but other than that, I think I have to go to the store too. But it's very weird. The streets are very deserted. It's very weird.
It is very weird, but thank goodness the technology allows us to stay connected.
Yeah, this is kind of amazing. So I'm amazed.
Work continues.
There's my eyebrow going. I'm amazed this works. Thanks for organizing it. I'm sorry I couldn't be here in person, but it seems like quite a few people were online. So hopefully people. Yep.
And our work continues, and we just hope that everybody in the ME community and fibromyalgia community across the world manage to stay in touch with each other through these times ahead. So, well, I think one thing is that in this day, right now, I mean, I will say that people with ME have the most practice probably of doing what they need to do to stay to not get coronavirus. I won't say to stay healthy, to not get coronavirus by. Unfortunately, many patients have long experience of being at home, very unfortunately, but I guess in this circumstance, it's what everybody's having to do. There's some expertise in this community, isn't there, to be shared? So, yeah. But for those who can still manage it, you can still go outside, you can still enjoy sunshine, you can go out with carers, but it's social distancing is what we now call it, isn't it? So
right, that's the phrase here. And one thing we actually didn't talk about is the potential, or maybe we did, or maybe it was before the talk began, but just the concerning potential that after this viral wave, we will have another wave, a secondary wave of ME or of an ME-like condition. Unfortunately, it seems likely, we don't know. So that's something I think we were discussing that a little bit before the talk started.
Yeah, I mean, that's why this talk still seems relevant. So we just hope that if that is the case, and I fully expect it will be the case, but I hope it isn't, but I'm sure it will be, that those people are fully believed.
Okay, well, thank you very much.
David.